I would thank my friend Abdullah for the nice invitation and Dr. Khan also. So I'll present, I won't present my surgery achievement, but rather I will present some cases that raise a question during and after surgery, and they can also spark our discussion after that. So this is a female with the macro hole, stud 3. I go for temporal inverted flap. After that, tamponade with gas. So here, PVD with triamcinolone. And then I start the inverted flap. I am convinced that minimal touch in surgery, it's the best for our specialty. So I didn't peel a lot. So this is one. I started at temporal and then I do the flap. Minimal touch, as said my friend Ahmed. And then I exchange, but 15 days after, the flap doesn't close the hole. I wait few days hoping that it's covered the hole, but no way. So I decide to operate and do something that I don't like. Do a lot of maneuvers around the macula, and we can remove fiber around. So fortunately, after that is closed, and the angel has not fallen, but the flap has fallen. After surgery, be scan. So I will share with you some poor prognosis factors for macro hole close before surgery, during surgery, and post-operatively. According a lot of discussion and publication, during of the macro hole more than 9 months, it's a poor prognosis, macro tape, and the size of the hole. Also the axial length, more than 30 millimeters. In our cases, we didn't complete peeling of AILM, I think this is the cause, and using triamcinolone can also don't close the macro hole, and the wrong position of the patient after surgery can also occur this situation. So to take home message, you can scan this QR code and go to the discussion. Thank you.
Thank you, Dr. Walid. Dr. Mohammed
That's
Maghazi.
great, excellent surgery. I actually do temporal flaps all the way, even in myopic patients. And I have seen those cases quite frequently. But I find it that, first of all, during the surgery, to maintain those flaps, you can either use PFCL, and this has been shown to reduce the flap slippage after the surgery. I never use PFCL. However, I take my time in drying the surface of the retina all around the flap. If you take good 5 minutes, and I counted over the clock, if you take good 5 minutes trying to dry all around, behind and interior to the flap with a soft tip, until you find this ground glass appearance of the flap, this guarantees you it will never slip after the surgery. In the case of those cases that slip, I find that you don't need actually to go in and remove more of the ILM. Either you have the flap, it's just dislodged, so you bring it back. If sometimes it's not there, I mean, sometimes you feel it's truncated or shrunken, so you cannot re-invert it. At that moment, you have a plenty of reservoir of the ILM. At that moment, I do a nasal flap, okay? But again, there is no need to remove all around the ILM. These are my 2 cents.
Thank you very much for this presentation, because I had confronted a case like that of failed macular hole after a temporal flap. And what helped me to get the hole closed is using the multiple flap technique, the envelope technique, to close the hole. Although the maneuvers, like Dr. Muhammad had said, is more difficult and more traumatizing, because you get the flap out of the papillomacular bundle which is very precious for us.
Thank you. Dr. Baha.
Yes, I am not using. I'm doing temporal flap, and I faced like this case. Now I am injecting heavy viscoelastic over the flap after drying of the.
Over or in the hole, you mean?
No, over the.
Over
flap.
the flap.
Yes.
Actually, it could be both. It could be because viscoelastic is sticky.
Yes.
Some people use also blood concentrate, precipitate of the blood plasma is also one of the maneuver. Also fibrin, tissue fibrin is another way to do it.
I don't need to prevent migration to induce gliosis. What is the rationale of this flap? Is to cover and until glial cells will come.
True.
So I'm injecting the viscoelastic over the flap, not under the flap.
I think just to make the priority is, I agree with Dr. Mohammed Maghazi, PFCL is very helpful because when you put it, then take it out later, you don't leave it. But you evacuate the fluid under the flap away, so you make it more sticky and as long as it could be. I think this is one of the easiest way.
I agree with Dr. Zayed. You have to dry a lot
And drying.
after peeling the membrane and fall over the hole. So I avoid to use PFCL because, like Hussein said, it gives a lot of inflammation and we can leave some bubbles in. I am sure that minimal touch it's good for our surgery. So I avoid to do a lot of maneuvers. So that's why I use PFCL when it's good to use it. So,
Less is more. Huh?
let's
Thank you very much. Our next speaker is